Bienvenidas todas las personas.
Welcome to all the people who are joining us in webinar number 144, since the Andean Health Organization Hipólito Unanue Agreement started a cycle of webinars in May 2020. We celebrate 50 years of the Andean Health Organization, of uninterrupted work, of joint and coordinated actions with the ministries of health of the 6 countries, Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela, with the vision of advancing in guaranteeing the right to health of the population. To begin, we will give 3 key messages. First, vaccination against COVID-19 is safe and effective. More people we immunize, the less likely we are to become infected, in addition to protecting us against severe forms of the disease. Make sure you complete your vaccination schedule. There is no excuse for not vaccinating against COVID-19. Second, climate change threatens life, health, and well-being. Like any crisis, it presents an opportunity for improvement. You can contribute to generate social policies and sustainable development model. Join an initiative in defense of the environment. Buy local products and plant-based foods. Use public transportation, cycling, and walking. Reduce consumption by reusing, repairing, and recycling. Restore a relationship with nature. Nature is health. It is essential to recognize the ancestral knowledge of native peoples who have lived in balance with Mother Earth and practice good living. Third, the multiple and complex crises facing humanity constitute urgent challenges for the continuity of life on the planet. Among other consequences, the socioeconomic and environmental context in the Latin America and the Caribbean configures a scenario in which hunger, food insecurity, and malnutrition have increased. This is a priority issue that requires political decisions to transform current agri-food systems so that they are sustainable, sufficient, inclusive, efficient, and generate equality so that all people can have access to a healthy diet. Reflections on this and other topics of great relevance to health can be found in the monthly edition of Andean Health Organization Bulletin, Notice Salud Andinas, available on the Andean Health Organization webpage. We invite you to leave your name, organization, and country in the comment box of the Facebook Live or YouTube Live chat. In the same space, you can leave your questions or send them via email to webinarhorasconu@gmail.com. In this webinar, we will follow the usual dynamics. We will start with institutional greeting, followed by the presentations of our speakers, and then we will move to the Q&A session. To access the certificate of attendance, as usual, in any of the chats of Facebook Live or YouTube Live, you will find a fixed link. You must fill out a brief survey and then leave your data for the issuance of the certificate. It will be sent in the coming days to your emails. To start this important day, I will give the floor to Dr. María Carmen Calle, Executive Secretary of the Andean Health Organization, who will give the welcome and institutional greeting. Go ahead, dear doctor. Thank you, Bertita. Well, we are in the International Day of Disaster Risk Reduction, and we would like to share with you that the Andean Health Organization Hipólito Unanue Agreement was established by decision of the Ministries of Health of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela in December 1971. Last December 18, we celebrated 50 years of uninterrupted work with the vision of making significant progress in the effective exercise of the right to health of the public. Since May 2020, we have been holding webinars every week. with the objective of promoting continuous interlearning. I cordially welcome you to webinar number 144, Disaster Risk Reduction. When in 1987, there was an accident at a nuclear power plant in Chernobyl, Ukraine, not only was there an explosion and the spread of radiation, but also the modern idea of risk exploded. Since this event allowed us to understand what is a collateral effect of modern scientific technological development. From then on, the comfortable distinction between natural and man-made risks has lost its significance, given the uncertainty of science itself to be able to differentiate between them. Understanding this is what the German sociologist Ulrich Beck has called reflective modernity and the risk. That is, the so-called natural risks can be magnified by human action. So being reflexive implies taking the necessary actions to prevent them and reacting in real time to such events, but also guided by an understanding of the correlation between natural and human causes, which could potentially help to avoid them. The Global Assessment Report, published in April this year by the United Nations Office for Disaster Risk Reduction, reveals that in the last 2 decades, between 350 and 500 medium and large-scale disasters occur every year. Human behavior is contributing to an increasing number of disasters worldwide, putting millions of lives at risk. The report attributes these disasters to a misperception of risk based on optimism, underestimation, and invincibility, leading to decisions that exacerbate predisposition and susceptibility to being adversely affected. The United Nations General Assembly has designated October 13 as an international day to promote a culture of disaster risk reduction worldwide. We can slow the pace of preventable disasters as we work to reduce inequalities and achieve the sustainable development goals. And we need to address the planetary crisis caused by climate change, biodiversity loss, and pollution. Our continued existence as a species on the planet depends on this. The theme, increasing the availability of early warning systems, reminds us that the goal is to avoid new risks and reduce existing ones. But when that is not possible, early warning system can enable timely action to minimize damage, people, and livelihoods. Today, with top speakers, we will analyze the main achievements, lessons learned, and recommendations for risk reduction and social management from the health. Welcome Viviana Cerón, welcome Diego Vallejo and Milton Napa, the old people who are joining us. Thank you, dear Dr. Marie Carmen. After the greeting from our Executive Secretary, I introduce myself. My name is Bertaluz Pineda Restrepo, Coordinator of Climate Change and Social Inequalities in Health in the Andean Health Organization. Today, I am pleased to be in charge of moderating this webinar. In the Andean Health Organization, as you know, most people that have joined many of our web seminars, we work with committees, and one of the very important committees that we have in our institution is the Andean Health Committee for Emergency Disaster Risk Management and Climate Change. In 2019, the ministers, in response to the work done by the committee, approved to change the name. That committee is now called the Andean Health Committee for Emergency and Disaster Risk Management and Climate Change. In relation to the mission and vision of our organization, we work to provide an answer to the Ministry of Health of the 6 countries to guarantee the right of health to the population. It is very important to develop meetings for change meeting and, of course, to apply with the Andean plans. We have 2 plans, the Andean Plan of Risk Management in Health Sector that will strengthen the capacities of risk management on the health sector in the countries of the Andean region, focus on the analysis and estimation of risk, prevention, risk reduction, preparedness, response, rehabilitation, and reconstruction through mutual cooperation, intersectorial and coordinated work between all the Ministry of Health on contributing to the sustainable development. This plan has 6 expected results, or to update on normality, risk reduction for disasters, preparedness and response to disasters and emergencies, mechanisms of mutual assistance and cooperation, capacity and competence of human talent, and climate change management. In 2017, in a meeting of ministries, they asked that in these objectives include evidence on how climate change has an incidence on health and in the increase. So with the committee and from the intersectoral effort, we developed several studies. The plans and studies are found on the webpage of the Andean Health Organization. For example, climate change trends and impact on health, situation analysis of emergency and disasters in health in the Andean sub-region. We have the Andean Plan of Health and Climate Change, following an analysis of the studies that I mentioned before. The committee decided that it was very important that climate change would not only be included as a risk management plan, but to have a specific plan to approach this complex problem. The goal is to contribute to the decrease of the negative impact climate change has on health from the population through strategies for the comprehensive and adequate management, intensification of cooperation networks, and a progressive integration among countries. The expected results of this important plan that was drafted with the committee, the coordinated effort in the different areas, strengthening capacity of human resource, intersectorial, multi-level, multi-factor, and interdisciplinary work, the epidemiological and health surveillance, the vulnerability analysis and risk facing climate change, research and systematization of experience and ancestral knowledge with sustainable and resilient health facilities, the care and respect of the environment and the ecosystems, health promotion and social participation, prevention and control of vector-borne diseases, zoonotic diseases, and extreme temperature diseases. You can find this Andean plan in the webpage of the Andean Health Organization. We invite them to visit there. There's always a message. Together we're together we go further, because problem cannot be solved if we don't approach it with an intersectorial approach. To continue, after this preamble, we're going to invite Dr. Viviana Cerón Rodriguez. Dr. Viviana is a bacteriologist with a master's degree in public health. She has work experience of more than 14 years in public health and environmental health, 7 of them in variability, climate change, and health. Her experience includes the development of consultancies with international organizations such as ECLAC, World Food Program, and regional organizations such as the Andean Health Organization, Fiocruz, Inter-American Development Bank, among others. She has also worked in the Ministry of Health and Social Protection of Colombia and as a lecturer in environmental health and climate change. She is currently a health consultant at the Ministry of Environment and Sustainable Development. Dear Viviana, thank you so much for accepting the invitation. We are very happy to have you here in this webinar. Go ahead, you have the floor. Good afternoon. Thank you very much for the invitation. I have a special love for your institution, not only because participating in process with you, but with all the work that you carry out in our country. And in celebrating this International Day, one of the most important elements is with regards to the access to early warning systems and the information and evaluation of the catastrophe risk. And in that regard, my presentation is going to be focused on some reflections, somewhat conceptual in terms of what have we developed and how, without climate surveillance, together with some topics of rights vulneration, can give rise to have a real-time progress in those early warnings in different time scales and at different space scales. This is the order of my presentation. I'm going to first speak about approaches, presenting something that we have developed with the ORAS, followed by mention in what scenarios and what time and context is that the countries are today, and then I will show you an example of that we are building in Colombia on environmental health. And finally, I will make some comments on the advances of weather or climate monitoring, and then come to a final conclusion. So, environmental health throughout the world, but also the risk management of disasters, has had different conceptual approaches, from the social determinants of health, another from the health social determinants, which is different to determinants. Another approaches are in itself from risk management for disasters, but also a model that we have developed in some countries in the region, which is a matter of effects, state actions. This graph was developed in a joint effort with ORAS a couple of years ago. I would like to mention that each conceptual approach although it has some degree of specificity, are absolutely coincident. In green, you can see the approach used in risk management that has been taken by the Intergovernmental Panel on Climate Change from the United Nations. In black, you see the category of driving forces, and in gray, what are the structural determinants that determine inequalities in health. In that regard, we can see that the driving force and pressures coincide to what we know of structural determinants, and the following categories that underlie in the driving forces and pressures, which are the state of the threat and the effects are coincide with intermediate determinants. And the advantage of this model is that for each category, we can generate indicators that makes visible what the action should be in order to deal with that disaster risk management, not only in containment of that risk, in the attention to that risk from different sectors, but how can we move ahead so these things are not cyclic? Because what we see in our countries is that due to given different scenarios, political, technical, structural, we are reactive. But given the conditions, we've been able to make progress in terms of the structural. And I will speak later about some elements that occur in Colombia. But it is basically that the conceptual model or the conceptual approximation is going to have a lot of coincidences. There is no important differentiation from the conceptual point of view. So each one of these is useful not only to take care of when there's a threat in populations at risk, but it also allows us to work on those elements that are of structural nature. Risk management in our countries has different scenarios. We have different elements that interact, and that multiple interactions generate several effects. But one of the, from my perspective, is more important are the social environmental conflicts through different production and consumption dynamics, understanding that these conflicts are generated when there's tension or lack of agreement between a private, some communities where you have some suppliers and consumption dynamics, but with the state in the middle, where the state cannot make progress in providing a solution, but they cannot guarantee the rights. And as Dr. Maria Carmen pointed out, if one right is missing, it includes all the others since they are interconnected. So if I have elements that prevent the guarantee of that right, I have communities that perhaps move ahead in that demand of the right, and in that regard, the state institutions have to deal with those social environmental conflicts that can have sentences of the different courts in our country, but also other legal instances. In addition, we have a disease, the normal disease burden, but we also have a disease burden attributed to environmental factors, among them those who cause the emergencies and disasters, not only in terms of how many died or get sick, but in addition are the effects on mental health. These are not a pathology like to feel sad, to lose my social network. This is not adequately identified. as a consequence. Another element that constitutes these scenarios for risk management is the land use planning. We have sectors in our country that have their own instruments or mechanisms for land use planning. Or at least in our country, what we see is that very few times there is coordination between, for example, the land use planning in terms of water availability, of the access to the resource, to the quality of the resource. But in addition, I have other planning tools from mining and energy and agriculture and health, etc. But they never speak among them, so there's no real land use planning. In addition, we have a social component that in our standards is the other sectors that think that health is only the health systems and health is not an outcome, that is care of disease and death, but it's just descriptive. So morbid mortality profiles, but they don't consider what are the interactions of all these elements so that I can learn about the risk, what is the vulnerability, and what are the characteristics of my threat. So in that situation, I can generate early warning systems. Clearly, what we have is a need to learn more about that not risk, not only for attention and contention, but also to make prevention, not only from the structural point of view, but from the intermediate point of view. And this is something that the early warning systems allowed us. So that if one having all these elements in increase, it adds a rights approach and then land use planning and the different ethnic groups, because they're usually the black population and indigenous population are the most affected, as well as children and pregnant. We could have more elements that could make this analysis more complex, but in that complexity, we can have response. In addition, we all have scenarios of climate change, being climate variability, a representation of that change in terms of that variability is present not only more frequently, but also with more intensity. But those climate variability topics that had a strong seasonality, it may be that under climate change, they may also change. And now we need to make good use of these conditions so we can generate adequate response before the threat can become a reality. For example, in Colombia, it's the same for us if it's a boy or a girl. At this moment, we have La Niña or El Niño, but for a long time, we know that this is going to affect us. We have characterized the threat because the institution in charge of characterizing the climate threat is adequate and is telling us, asking how can the different sectors mobilize with regards to these alerts, not only the health sector, because we have to deal with people who are ill or disability, but the rest of things are in other sectors. I would just like to mention that we always see the same things and the same populations that are affected, and that is to accumulate effects. I don't know if you heard about San Andres. This is recovering from a climate threat. Things are slowly going back to normal. They have this new threat. We haven't recovered fully, and it comes back and this explodes. We do nothing. Other elements are to learn what are those dynamics of consumption, extraction, for example, mining activities, the land planning, but we are still doing the same thing. This is my reflection that it is important to take care and recovery, because those are the acute effects, but what happens to the cumulative and chronic effects, but also what happens when there are many things that from the national levels we don't know about. And in that regard, instead of having a from top to bottom dynamic, what's more important is that we have elements that will allow us, our territories, have how we include a national policy, but also how we act to have a preventive approach of mitigation and capacity generation and adoption if we're talking about climate change, but also since resilience, which is intrinsic to the topics of environmental health. This slide is to show you how the environmental health is operating in our country. This is an approximation that has allowed us to act and recognize the influence of other sectors in terms of energy matrix, land organization and planning, the ecosystems, but having an umbrella with environmental justice and climate justice. So this is highlighted in the priorities and is like to understand that risk at different space and time scales, but also the institutionality and the organized social response will allow us to move ahead in governance and also in guaranteeing the right. That frame of environmental and social justice, we have these impacts that we see or are more visible, like flooding, when we have drought, with the repercussion on specific social determinants of health, but also their own effects, and how I could rank a heat wave as a disaster or other types will not consider, but could become a disaster if I don't take into consideration the livelihoods, how those climate elements and those surface variables in the atmosphere behave and may generate a disaster that are not visible in biophysical terms, but instead they are seen present in terms of migration due to climate migrations. And this climate migration not only has effects on health, but also on those livelihoods, on some type of acute communicable diseases, and how my social dynamic change, how my environment change, my whole house. In our countries, it is very common that I talk with my neighbor and have a social network in my neighborhood. But when we have a disaster, that network breaks. But sometimes when it can be rebuilt in the short term, it becomes stronger. And that is going to allow us not only to consider when those disasters occur, I should not only have that care, but also how to rebuild those social networks that support not only livelihoods, but also my mental health. And as I mentioned before, in terms of affectations, sadness, I feel sad because I lost my social network, but it also generates anguish because I lost my livelihoods. And the important thing in this matters, which is not only to deal with acute diarrheal diseases or acute respiratory diseases or others, the typical things that we see in a disaster or emergency. We also consider how can I do this containment of the emotional effects that's not only in the individual but also at the level of the community. Finally, I will make a call. From what perspective should I understand risk? I'm just going to learn about the threat and what could possibly happen if I have some territories under social inequalities, but I also have people are not vulnerable, but there's some rights that are vulnerable. So how can I understand the risk from that perspective? In terms of priority two, governance, what is the best way that we have in our countries to generate a governance? How should we understand each other from the institutions of the best way so the social organizations and communities generate those synergies between institutions but also communities, because those are the ones who know their territory best. And one many times from the national level or the local government level cannot understand them completely. And another element is, well, we can do that, but what happens with the communities that every now and then suffer the same problem? And what happens with those cumulative impacts? That is not only the cumulative impacts on the biophysical, also in terms of that vulnerability of the right. And finally, the structural and proximal. What kind of investment should we do and how should they be done? The land use planning, considering different threats, but also the state at which that vulnerability exists, so that we have one important element, which is climate, or these atmospheric surface variables can be one of the best predictors to have early warning systems, but these early warning systems may not be national, but have to have that differential approach in terms of territory, ethnic, and also in the livelihood. So that in our countries, we have some climate dynamics, but also we have the knowledge of that climate and how can I, from the different sectors, put that climatology knowledge to do a real approach of prevention from the structural, but also how can I anticipate to that risk to decrease its magnitude. And that is what I wanted to tell you. I didn't focus on what we know, following the invitation of the authors to provide more reflections. Thank you very much. Thank you, dear Vivi. Excellent presentation. You show us the conceptual framework the scenarios for risk management, importance of conceptual clarity. I would like to this of what Viviana mentioned from the Intergovernmental Group for Climate Change, and the concept of vulnerability has to do with the profession and that interesting link that can be established with the human right approach and the social determination approach, and of course, with risk prevention to guarantee life, health, and well-being of the population and everyone in relation to the care of our Mother Earth. Congratulations and many comments and questions. Please stay in the room because following the presentations, we will go to the Q&A portion of the program. Thank you very much. Now we will continue with the presentation of Diego Vallejo Arias. He's an engineer in risk management, master in integration of management systems, has a postgraduate degree in environmental health, among others. He is currently the director of the National Directorate of Risk Management and is the president pro tempore of the Andean Health Committee for Emergency and Disaster Risk Management and Climate Change of the Andean Health Organization. He has 24 years of experience at the national and international level as an Undersecretary of State, university professor, and senior specialist in the field of design and implementation of integrated systems with emphasis on risk management, emergency response, evaluation of development projects in adaptation to climate change. He has developed different activities in Ecuador, Asia, Africa, Latin America, and the Caribbean. Has experience in risk analysis of significant projects in Ecuador. We welcome you, dear Diego. Go ahead. My dear Berta Luz, thank you so much for this introduction, very kind words. And it is an honor to share with you in this space from the Andean Health Organization Committee for Disaster and Emergency Risk Management. This is a committee made up of all the heads and responsible of departments, programs from the Ministry of Health, and also these officials in charge of the adaptation plans to climate change, and also with the environmental health offices. This program or this committee have had the valued support from ORAS and from the Pan American Health Organization, who allowed us to look for these new steps in this major challenge with the integration of the health system of these two critical variables, such as disaster risk reduction, as well as climate change management. This space of celebrating the International Day of Disaster Risk Reduction, the health sector has been one of the most affected and less visualized, with the exception of the pandemic, in terms of the management of disaster. And in this context, and for this presentation, what I would try to share with you is the approach from the different processes that need to be executed by identifying what has been these interesting experiences that have generated very interesting results in the general risk reduction. The risk is not for climate change or health or the mining sector, but we need to see it from a comprehensive perspective that covers and allows us to understand, as Viviana mentioned, combination of a process of development on an environment, and that the lack of compatibilities in this environment are going to generate a risk that may potentially be translated in an adverse event, that if we can manage or if under the possibility of control from the affected system, it will be an emergency. And when this is overcome by the response capability, we need some external support. This becomes a situation of disaster or catastrophe that somebody else calls it. So in that line of work, the objective is to analyze and discuss with you the main achievements, lessons learned, and identify some recommendations that are a priority from a viewpoint of a diffuser of these lines to see how we reduce this disaster risk that overcomes the capacity of response, especially in the health sector. So we're going to use three matrices that in this methodological context of the six process of risk management, we find the actions that should be strengthened and the actions that should be reproduced or replicated because they have certain level of significant contribution and success in risk reduction. As a general context, then, we to these six processes that have been adapted by the Andean community through the FEDECAM project in Disaster Prevention Committee. First is to generate the knowledge on the disaster risk in different scopes, called the interpretation of risk or analysis of risk, which is a cross-sectional element. It's been said that risk analysis comes before prevention, and actually risk analysis is done in the other five processes as a starting point of each one and the evaluation of the levels of implementation of management actions in each of these processes, and finally as a delivery for the next management element that, depending on the circumstances, it could be a reduction, a preparation, or risk. Second element is the prevention of future risk, what is called prospective management of risk, understanding what could happen. The second element to reduce the existing risk, the corrective management of risk. In some cases, our actions and the incompatibility with the environment can exacerbate certain types of threats, or the vulnerability conditions are extremely high and we cannot face this threat that we are facing. We need to reduce to a certain threshold. When this residual risk cannot be managed and we see the threat, this generates an emergency that requires a preparedness process. That is number 4. When we have the human talent and the software, the hardware that are trying to be ready in case this threat becomes true, we can deploy the different resources to recover the control of a destabilized process in disaster or an emergency. And then we have the process 5, which is the response and rehabilitation. So the vital systems that have been affected can go back to becoming available to the users. If, for example, if we lost its energy grid, the regular energy grid or public energy, this response can be with generating plants to return the power service in the short term and allow us time for process number 6, which is recovery and rebuild. So under this risk management parameters, I have identified the following situations that may be different for each, for stakeholders or countries, but you may say if this priority is indeed the most important one, or this, the one identified is not seen in my experience in my territory, but we'll try to generalize these elements. So by pooling perspective and corrective management, there are some scopes that have been considered, such as health sector specifically, which is the generation of regulation and tools, administration, quality standard, financing, and sustainability. What achievements we had in regulations and tools? They are regulation and tools for hospitals like ISH, which are the hospitals security indexes that allow us to measure the likelihood that the facility continue operating when there is an emergency, either internal or external. On the other hand, we have in this the licensing and construction standards. This has allowed us to use this functionality in terms of design, application, and operation of the different elements of health, from service delivery. What lessons have been learned? Although it is true that we have these achievements and these tools, the RAP is the violence management tool that have been learned here is that the risk variable should be included from the first stone, from the first brick. When the hospital is in process of construction, where the land is being prepared for the construction, it is very expensive to generate the necessary corrections so the level of risk is in agreement with the environment where this health unit will operate. And this is not only the biotic, but also the abiotic component. And we have also an impact on social component. The threats generated by violence on health operations are becoming very strong, and the actions, if hospital is built in the safest place from the natural threats point of view, but in terms of the social issue, they may have a lot of problems with this interaction, understanding that the territory has more variables than just the physical ones, has to be included and managed since the early stages of planning. What are the next steps? Is to generate regulation with minimal protection criteria, not only for the user, where we have made a lot of progress with the quality standards and patient safety standards, but also protection for the staff and the users into whom we are addressing when we carry out extramural activity. In terms of the administration, we need to recognize that both ministries and health units have strengthened their risk management teams. They have been organized, and we can say that in 80% is theoretical from the visits I've done, both at the national level as well as the regional level. You will find someone who's in charge of the risk and managing the hospital or the bureaucrats that are necessary for this managing. Lessons This risk team should be at the advisory level of the authority. This is very important because the dependence of an operational management generates some limitations, such as is the case when we have been a judge and part who's responsible of the fire in the hospital, risk management or the hospital manager. If the hospital is with no medications, the responsibility is from the manager. And similarly, when there's a fire, the hospital manager is the one in charge of all these operations, and risk management, what it does is to advise the decision process to guarantee a safe operation, in continuous operation that protects the infrastructure. What are the next steps to guarantee access to authority as part of the team of risk management team through changing organization, but mostly in the training of people for risk management so they can speak in the managing language, and this language is the first one to be heard when there's the need to take a critical decision by the administrative authorities in terms of quality standards. There's been a partial incorporation in certain, for example, interesting achievements, but they're difficult to quantify. These been a lessons that we learned. We've done many events, trainings, but how much of the risk can we have been able to manage? What is the inclusion of climate change in risk management in adequately administered? And this may have been added elements need to be visualized in a more quantitative way, and that would allow to see tangible results in terms of the end user. Unfortunately, if we do a good risk management, nobody will see it because prevention is invisible, because the element is still operating with, with any problem. You see the risk managers when things are out of control, there's a loss of governability. This is when they ask, why didn't you do that? Why haven't we worked together? So these elements need to be associated to financing. The important achievement is the health infrastructure. But we have not reassured continuity. How can we ensure the processes in addition to the structure? And it needs to be integrated in the operational programming. Risk still competes with other sectors in terms of budget because it is difficult to visualize, and this is one of the major challenges that we, the risk managers, have in order to make us visible and influence the decision maker, who's our most important client, on how do we with risk management. And we need to, the next step with the drafting of the budgets and to take them towards a permanent management of our health institutions. Now, in terms of sustainability, there are many achievements, there are many specific projects in risk management that run out of financing and unfortunately generate a process, lots of interest because we're not able to be coordinated. And this has been projects that are managed in a fashion from the rest of the management. And here, this is it is to try to understand that there are many specific projects in climate change that has 80% relationship with risk and vice versa, and they're also being managed strategically, understanding that financing lines are also specific. However, when we execute a management, the relation between these two spaces of risk and climate change cannot be broken down because they're looking for the same thing, which is to maintain the threats within conditions of safety and that these are within the thresholds that are accepted. So this should migrate, specificity of projects should migrate to programs to highlight the role of risk management as a cost reduction tool. Dollar invested is a dollar that's protected, and we need to understand that the most important work in risk management in general terms is protection of the investment in physical means, in terms of structural and non-structural, and also in social and environmental terms. We require this visualization to understand how much is being protected when we carry out investments in risk management. In terms of preparation, of preparedness and response, we have these 5 elements. The first one are the administrative elements, where in almost all the health facilities and administrative processes have achieved the of response plan.
Diferentes nominaciones, planes de preparación, perdón, planes de respuesta, planes de
response plans, contingency plans, whatever name you want to give them, sometimes creates confusion. Is that it is the understanding how I'm going to operate and with what resource I'm going to operate and how do I reorganize when a threat is close to us or has already started in a health. I think that the hospital planning tools are strong, but we have seen that there's no multi-threat system has been established, and with COVID, we've gone through a specific or experience where we had the biological disaster mixed with other type of social threats and earthquakes and meteorological phenomena, and it also increases social threats. And although it is true that our contingency lines may be specific, we need to look for wider spaces that will allow us to deal with different elements and to dismiss the cause in this process of preparation and response, to dismiss the cause and focus more on the impact. That is, you can receive 10 persons who have a traumatic injury, and these 10 persons can come from one transit accident or an earthquake or a jail mutiny. So when we elaborate a response as operational determinants, the causes may be significant, but when we're dealing with them, we need to be more prepared to consider the impacts and let prevention and reduction can do their thing. So that has to do with the quality of the events that will be potentially triggered in a territorial space. As the next steps is the integration of preparation as a substantive and not adjective. What do we mean by this? Although risk management is an advisory process, but the preparation and response should be integrated to how we do business in health, how do we do healthcare and the way we do health sanitary operations. We need a preparation and response similarly to what we have as a manual and a role description or job description could be managed strongly and evaluated managing factors. In the next element, we are established the minimum standards of preparation and response, except some specific elements like minimal oxygen capacity. We don't have a standard in terms of reorganization of the systems. This has to be stated and evaluated through simulations and drills that are mostly demonstrations. We need to have a quantitative assessment of hospital capabilities in emergencies and disasters, as well as the rest of health operations, not only to protect the users, but also our team who is providing care. In terms of warning systems, there's been an integration of information sources. And here, the alerts are communicated in real time. And the ones who have social origin are taking more time in their reading, and in many cases, it goes through a political wish of not showing the so we don't see that there's a management problem in terms of controlling these social elements, and this sometimes makes the alert, there's a delay on the alert. In human talent, there's a specialized professional training. We have undergraduate, postgraduate training, and there is this offer. However, the competitions are voluntary. But for some levels, they have a specific function, but in risk management and the components of preparation and response, these are not part of the operations manual, but are an additional element that if you want, if you please give us a hand being part of the team. In terms of command and control, I would like to highlight standardization that we see in Latin America. In Latin America, we use the same system of emergency management where they have a common language. The working stations are the same and are within the same components of understanding, and that has facilitated that units can have an international work and that the technical language is not a barrier for this implementation. However, this is quite strong at mid-level position in the operations staff, and this needs to be communicated to leaders as a next step, understanding that the authorities and leaders have a high degree of rotation. So we need to be prepared for this rotation as a part of the way that we have to guarantee our authorities can understand actions in this field. In terms of the risk analysis, the standardization and tools have been created as a space to prioritize, but these methodologies are not integrated. each one of these tries to measure a specific element to comply with an indicator, but we don't understand how these get together in an integrated system of risk management, and we require that this needs to be managed in a comprehensive way, and management to also be integrated in to optimize costs and not be fighting for. In terms of the administration, there's an institutionalization of health managing policies. It's go towards the national systems of risk management, that health is not an isolated element, and that health is part of the national system for risk management, but that at an administrative level, how to bring this down towards the territory is the next challenge. Many of the policies and tools can be applied to large hospitals, major health operations, and large campaigns. But what happens on a daily basis with our extramural process where we have operational staff in contact with people? Are we landing the risk management projects there? This is something that needs to be strengthened. Instead, in terms of safety standards, there are certain qualitative acceptance thresholds that have been designed and have allow us to start with managing and prioritize certain actions, but we need to move towards to a quantify the risk level and compare it among hospitals, among sectors, sectors versus the agricultural sector. That's the next step. And for this, we need to generate a sort of strengthening of the health sector itself, but also finding the necessary lines so that rest of these sectors can be analyzed in the same way and integrated into a single decision-making schedule. Here we can see, for example, that when we do an investment project other than health, or like such as a mining project, you have the environmental variable, the social variable, the economic variable that play a role in a coordinated fashion in sustainability principle. However, the risk variable is maintained, it's kept isolated in this decision-making process, and it follows its own line with no support from a political opinion. So decision can be taken on regards to continuity of the project or to modify it until the risk level agrees with the environmental space where this future project is going to be developed. Finally, the integration and sustainability topic, where there's no evidence of project or a program that will tell us this is how we are integrating elements. There may be some isolated experience that has not been sufficiently communicated, and that it may be used following an identification exercise of experiences. This can be managed such a way that we don't fall in temporal initiatives and being able to work them integrated to how the different entities make business and that are involved in this management. Finally, the next steps, as I mentioned, is that we need to have a multi-sectorial perspective and to use it as a real tool for cost reduction. We have to consider this economic situation because the competition for resources in risk management requires money, and these are not visible. The risk per se doesn't reduce the risk, and worse, it may be seen as the actions that will be specific and generated by other operations areas. Finally, the components of recovery. Why have not been developing? Why are we thinking here uh, at the level of country? We propose the new health regulations, the recovery component, once we have done a rehabilitation, when we are rebuilding, for the Ecuadorian case, it's being managed as another prevention. So we go back to prospective risk management because what we need is either to do a new work to recover the service or this new facility that's going to be new, but in the same space will comply with the new standards and the new acceptance thresholds for risk. So this could generate a structure without having to do with a social risk management that will have worse consequences. So for us, the final recovery process, a proposal under discussion, becomes a part of prospective risk management. This is what I wanted to share with you. As I mentioned in the start, we will not always agree with this prioritization. However, it's an analysis from the experience more than a what we're looking is to find what is good for us in this context. Bertalu, thank you very much. Thank you so much and greetings from Ecuador. Thank you, dear Diego. Excellent presentation. Told us the methodological context integrated with the Sendai framework with the risk management and the plan and other regional instruments that emphasize prevention, reducing the risk, preparing the response, rehabilitation, recovery, rebuilding. I would like to take the opportunity of the emphasis that Diego has put in prevention. What are the lessons learned, the effort in the need of reducing risk with a focused approach of the importance of having early information measures to have a quick report when there is a emergency such as a tsunami, a cyclone, or volcanic eruption. A person can make decisions based on those information and alert systems. Extremely important of today's topic. There are many lessons learned and many challenges that we still have, but there's no doubt that there has been some progress in each Andean country, also as a part of the integration. Thank you so much. We received many positive comments congratulating you for your presentation and many questions. Please remain in the room. Following the presentations of Nilton Napa de la Cruz for the Q&A, we welcome Dr. Nilton. He's a surgeon graduate from Universidad Nacional Mayor de San Marcos, specialized in health management. He's currently a technical advisor to the General Office of Disaster Risk Management and National Defense in Health of the Ministry of Health in Peru, partial reviewing and formulating policies and regulatory documents related to disaster risk management in health. A large experience in everything related to risk management and disasters in health. Thank you, dear Nilton. Go ahead, you have the floor. Good morning. First of all, can you hear me? Can you see my screen? Yes. Good afternoon. Thank you, Berta, for the introduction. First, on behalf of Dr. Pedro Crisostomo, the Director of the General Office of Risk, Disaster, and National Defense in Health, we thank you for the invitation. And in this opportunity, we're going to talk about the experience of the Ministry of Health in the implementation of disaster risk management, but in coordination with complying with the strategic access of the Andean health in disaster risk management. So first, we need to indicate that the Ministry of Health for the implementation of disaster risk management has defined an organic unit, the General Office of Disaster Risk Management and National Defense in Health. As you can see, we depend on the Vice Ministry Office. I would also like to mention that this office in its internal organization has created working teams, and among those working teams, they are the ones in charge of the implementation of several systems and laws, being one of them the National Law on Climate Change and Disaster Risk Management. Another important topic I would like to comment is that the National System for Disaster Risk Management in Peru is made up that the president of the first minister's office is the ruling institution, and we have some other institutions. We have the CENEPRED that is going to create the standards for the estimation, prevention, reduction, and reconstruction processes, while we have another institution called the Civil Defense National Institute will regulate preparation, answer, or response and rehabilitation. In the Ministry of Health, it will be an execution institution. And although it is true that these two institutions are going to provide guidelines for the implementation of those processes, we as the Ministry of Health will also draft standards in coordination with these guidelines from these two institutions in the national risk, disaster risk management. We have participated in the coordination of the Andean Plan for Disaster Risk Management, and we have taken note of the results, and we have coordinated to the strategic goals of our institutional strategic plans and more operational activities in our institutional operations plan. So now we're going to talk about the first strategic axis, which is updating regulations. For that, we will say that one of the parameters that we use as a Minister of Health to identify and identification of strategic processes where we want to implement some guidelines. What approach is that to a single threat or multi-threat, and the level or scope of analysis, we have the territorial approach as a national province, or if these regulations is considering the institutional approaches like the administrative offices or health facilities. And down here, we have the national policy for safe hospitals, where it is the implementation of prevention and risk reduction and the approach for health facilities, and therefore we recognize these parameters to update our regulations. As I mentioned, the Ministry of Health has entities or institutions at the national levels, like INDECI and CENEPRED, that are going to give us national standards. And we are coordinate our national standards that are going to implement CENEPRED as INDECI, and the the Ministry of Health regulations are sometimes considered working plans. Then we should also state that every year we approve regulations, regulatory documents. For 2022, we had 18 documents in GRD for approval. At present, we only have 8 requiring approval. 2 years ago, the one highlighted in red was approved, which is the means of contingency plan for the effects of heavy rains, floods, and mass movements. So this documents, regulatory document portfolio, is updated month after month to see compliance in terms of approval and implementation. In this strategic access of updating regulations, the most important achievements in establishing our own documents. And although we have national regulations, that national regulation is quite general and falls short for the implementation of health risk management. So that's why we have our own regulations. In addition, with these documents, we strengthen our action on the risk management in the health sector, and these documents are also useful for an intersectorial and interinstitutional coordination for the formulation of normative documents. One of the important things that I would like to mention is that for the implementation of these plans for risk management, we have a budget program which is 068 for vulnerability reduction and emergency care, which has its own activity and financing. As a lessons learned, it is important to strengthen the knowledge and competence level of public health officials because this is extremely important. We need to guarantee the permanence of trained personnel because we create the standards and we train them, but then they rotate. So we need to have this permanence of trained personnel. Training must be constant. And in addition, in every region, another thing that we, as a challenge, is updating regulations. We have many regulations that, although it is true that we are doing its implementation, there are many planning and investment mechanisms that we need to improve coordinating with disaster risk management. And although it is true that we have a budget program for the standard documents, financing is limited. And there's the intersectorial and interinstitutional coordination is limited. With regards to the second axis, that in the estimation of risk, to create documents, we at the national level have instruments and we focus in the evaluation is to a single threat or multi-threats. When it's a single threat, we have instruments like the risk scenario, which are more general documents that describe the level of risk based on the territory, and we have a risk assessment, which is more specific to determine the specific interventions in that area in the scope of investment. And in the level of multi-threat, we use this multi-risk risk evaluation, and it's not analyzed through territory or area, but what are those threats is of the highest risks in that type of plan. So one of the things that we need to consider is that many of these instruments that we have drafted are national level instruments. We don't have our own documents, but we work with the Pan American Health Organization to have our own documents or instruments. And we have the STAR, which is a strategic evaluation of risk with a multi-threat approach that we use for our operational plan, and the STAR H, which is a strategic evaluation of risk for health facilities. These are currently receiving training, and we will do the implementation. These are the risk scenarios that will work as a health sector through low temperatures, flooding, and mass movements. Among the achievements of this strategic axis, we have developed several scenarios for specific threats in our national regulation. We have coordination with the Pan American Health Organization. where we are doing the implementation of the multi-hazard approach or multi-threat approach as a strategic at the territorial level as well as for health facilities. There are cooperation mechanisms in place with technical scientific institutions, and we do this together with other scientific institutions that have to do in terms of rain, soil, etc. And we have a risk atlas at nation level, which is an application that identifies the health facilities by areas of threat and risk. In terms of lessons learned, we have identified for this implementation that it's important to strengthen the knowledge of the technical team in the elaboration of health risk scenarios at the three levels of government. Because many times those risk scenarios are carried out by us as Ministry of Health, but in terms of the local or regional level, it's difficult to create this type of implementation of those instruments. We need to guarantee the use of technologies and the necessary team to create this type of document and for an adequate monitoring of threats. Among the challenges, hiring of professionals with the expertise of the level of creating regional and local health maps. We also need to have adequate funding for equipment. And another thing that is important is that although it's true that we have national regulations and we can coordinate with health, we don't have our own standards in health that has been approved for this type of scenario and risk evaluation, and it will be important to have it. With regards to the third axis in emergency and disaster risk preparedness and response, one of the things I would like to mention is that we have approved a document where it establishes the emergency center operations and the spaces for monitoring, which are basically the institutions that are going to identify or analyze the threat. And in addition, we're going to propose some type of this regulation. It's going to give us an how we need to organize that working group or that working team to monitor threats, and also has a type of outputs in terms of monitoring. And this document related with COE Salud, the regional monitoring space, and the coordination with other COE at the national level. Both we as an operations center have coordinated with other ministries and also at the national level. So it also establishes coordination in terms of our information. In addition, we have a flowchart of information process in emergency and disasters. So this information flow in a validated and concise manner can reach and report to the working group, which is the Emergency Operating Committee of the Ministry of Health for decision making. Also, we have a informatic application, which is the CIRET, where all the data during the emergencies can have statistical reports, and we identify this CIRET, the vulnerable population, the events, and the monitoring events maps. And in this application, we can identify the health facilities that have been affected and what the Ministry of Health does in this event, and we present it in this manner. This is what we call infography. So this is information in this CIRET that has been validated. It's presented to decision makers by this type of detailed summary with a mapping of the interventions and risk. This is for low temperatures. This is what we presented for the COVID-19. In strategic axis third of emergency and disaster risk preparedness and response, one of the achievements is the efficient and timely communication. And we call it timely and efficient when the validated report is less than 2 hours. In 2018, 30% of our units reported. Today we have 60%, but we will have to reach 80%. Among the lessons learned, we should put emphasis on the information verification validation mechanisms because it's one of the important things that we need to implement. Because you must understand the social networks and social media and the rumors sometimes are in, there's no agreement with information that we have and that one that the population has. And to have professionals that may prepare maps and scenarios in real time is very important. Many times we have to identify in real time our interventions, see if this is accessible or not accessible. Among the challenges that personnel has a full-time and works exclusively. We have limited resources and that diminishes the need for the production of adequate information. We need to guarantee access to internet and computer systems in the areas of different access where perhaps these systems are lacking. With regards to the strategic access for mutual assistance and cooperation mechanisms, here we have a document for international humanitarian assistance in terms of human resources. For example, in the COVID-19, we've used this tool, see the equipment and machinery, and how we're going to do the procedures for the medications. These nationals, in addition to this standard regulation, we have our own, the Donation Administrative Directive that regulates the management of donations in the framework of the Ministry of Health in situations of emergency and disaster. And through a legislative decree number 1460, states that the Ministry of Health must formalize the acceptance of donations through the issuance of the corresponding resolutions. Now, with regards to cooperation in the presidential meeting and financial cabinets of Ministry of Health,
y tenemos los planes quinquenales de frontera con Ecuador, con Chile, que son los aprobados. Estamos trabajando actualmente con el de Bolivia, con el de Colombia y con el de Brasil. Todavía estamos en conversaciones, pero entre los dos aprobados tenemos dos ejes que son importantes que se va a implementar. El primero es el eje 3, que es la respuesta binacional frente a emergencias y desastres, y el eje 4, que es la atención binacional en fronteras. Entonces, esos dos ejes son los que vamos implementando con este tema de cooperación con nuestros países hermanos, ¿no? Dentro, digamos, de lo que es, digamos, los logros que hemos tenido, es que existe un compromiso para la asistencia mutua y cooperación en lo que viene a ser gestión de riesgos de desastres, ¿no? Y que es importante que lo lideren nuestros ministros de salud. Dentro de las lecciones aprendidas es que estas actividades de asistencia y cooperación deben ser monitorizadas, y para eso necesitamos articular digamos, actividades específicas para el monitoreo de este tipo de asistencia mutua y cooperación, porque muchas veces nosotros proponemos incluidos en los planes, pero no lo monitorizamos, ¿no? Porque no tenemos de repente identificado ese tipo, digamos, de actividades en nuestro plan operativo. Dentro de los desafíos que hemos visto es el tema de elaboración de guías. Muy bien, tenemos resoluciones, pero la parte de instrumentalizar esa asistencia humanitaria, esa cooperación, sobre todo en zona de fronteras, no está. Entonces tenemos que esos procedimientos estandarizarlos. Además de eso, el articular y coordinar acuerdos bilaterales para un acceso recíproco y efectivo en atenciones de urgencias y emergencias. Básicamente estamos hablando del intercambio prestacional. Nosotros decimos que las emergencias no tienen bandera. Entonces, ese tema del intercambio prestacional, de cómo te voy a apoyar o mis establecimientos van a apoyar, es lo que nos está faltando. El otro tema es el adecuado seguimiento y monitoreo de estos acuerdos bilaterales. Con respecto al eje estratégico número 5 de capacidades y competencias en talento humano, nosotros lo dividimos en dos partes. Uno que tiene que ver la competencia del nivel nacional y otro a nivel, digamos, de las regiones, ¿no? Más, digamos, o redes, ¿no? De nuestras provincias, ¿no? El primero tiene que ver con la capacitación en lo que viene a ser gestión de riesgo de desastres, ¿no? En el cual establecemos cursos, programas, diplomados, y el otro viene a ser con el entrenamiento de habilidades en lo que es prevención, pero enfocado a la comunidad. Dentro de lo que es, el tema de la comunidad, trabajamos bastante el tema en los simulacros para el tema del el apoyo en lo que viene a ser primeros auxilios, apoyo de repente en traslado de víctimas, ¿no? De esa manera trabajamos el tema de capacidades y competencias en el talento humano. Bien, y dentro de lo que es capacidades y competencias en lo que viene a ser de talento humano, nuestro logro, entre el 2020 y 2021 hemos certificado 1.339 participantes de todo el sector salud en lo que es gestión de riesgo de desastres. Estamos ahorita justo haciendo el curso de índice de seguridad hospitalaria. El año pasado se capacitó a 233. En esta fecha, en esta temporada, queremos llegar a 600, esperemos conseguirlo. También tenemos el curso de gestión de riesgos asociados a cambio climático. Se ha certificado 161 participantes, pero en este momento se está llevando a cabo otro curso en el cual se espera 1.330 participantes. Actualmente está en proceso el curso de brigadistas y formación de brigadistas para lo que es la intervención inicial, ¿no? En lo que viene a ser la respuesta ante emergencias y desastres, y el curso ICH y de GRD, pero nuevas ediciones. Dentro de lo que son las lecciones aprendidas, es que es importante contar con un compromiso de nuestros directores, de nuestros funcionarios, para que le den permiso al personal para que pueda realizar estas capacitaciones, ¿no? El utilizar una adecuada plataforma digital accesible, con tutores que estén permanentemente para que ellos puedan terminar de hacer estos cursos es importante. Y una vez de eso también el tener cursos aislados digamos, no cumple los objetivos. Lo que estamos tratando de hacer ahora es dar un paquete de cursos como un programa. Eso es lo que queremos. Dentro de los desafíos, fortalecer un equipo, un área, especialmente para el tema de competencias, contar con un adecuado financiamiento para contar con profesionales en elaboración de sílabas, rúbricas, diapositivas, grabaciones, que es otro trabajo, aparte del trabajo que nosotros realizamos como equipo técnico, ¿no? Desarrollar un programa en gestión de riesgo, ya no solamente cursos aislados, ¿no? El desarrollar una malla curricular también en lo que es gestión de riesgo de desastres, ¿no? Es importante, y que solamente se ha podido aperturar cursos, digamos, con la Escuela Nacional de Salud Pública, pero ahora queremos hacer diplomados y maestrías. Por último, en lo que viene a ser gestión del cambio climático, decir que nuestro ministro de Salud participó del cambio global del Ministerio Climático, se comprometió a la lucha contra el cambio climático, y el Ministerio de Salud ha aprobado una programación tentativa de las condiciones nacionalmente determinadas en lo que es adaptación en salud frente al cambio climático, y esto lo hemos aprobado este año, el 11 de agosto. Esta programación tentativa tiene 5 ejes. El primero tiene que ver con la información de variables climáticas ambientales en lo que es la vigilancia de salud pública. Básicamente están relacionados a lo que es la peligro y la vulnerabilidad asociados a lo que es el cambio climático, vale decir, investigación. El segundo punto tiene que ver con la gestión integral de cambio climático, pero incorporarla a los documentos de gestión, ¿no? Básicamente para institucionalizar el cambio climático a nivel del sector salud. El tercero tiene que ver con los recursos humanos capacitados en la gestión integral de cambio climático, que estamos viendo que lo estamos desarrollando. El cuarto es trabajar con las familias vulnerables en estrategias de intervención en promoción de prácticas saludables ante la ocurrencia y peligros frente al cambio climático. Y la quinta es identificar establecimientos de salud vulnerables que implementan medidas adaptativas en lo que es el componente de infraestructura, arquitectónico y organización ante los peligros asociados al cambio climático. Dentro de los logros de este eje estratégico son instrumentos de planificación aprobados, que les hemos mencionado, con enfoque territorial al 2030. Tenemos una incorporación de acción estratégica multisectorial en lo que es cambio climático y lo hemos articulado a un plan de la política multisectorial en salud del Perú al 2030, ¿no? También de eso tenemos el primer prototipo del Observatorio de Clima y Salud del Perú, el cual incluye el primer prototipo de repositorio de la vitrina del conocimiento de clima y salud. Tenemos una línea de investigación de cambio climático y determinantes sociales a nivel del Ministerio de Salud. Se vienen desarrollando cursos especializados para el manejo de variables climáticas ambientales en vigilancia y salud pública. Se cuenta con una propuesta de lineamientos de inversiones en los establecimientos de salud con la mira de lo que es cambio climático y con el apoyo de salud sin daño. Se ha dado inicio a una iniciativa para calcular la huella de carbono en un primer grupo en 20 establecimientos de salud. Con respecto a las lecciones aprendidas, es una de las lecciones más aprendidas, es la articulación que tenemos que hacer a nivel multinivel, multiactor y multisectorial en la implementación de estas acciones para que tengan un real impacto, ¿no? Se tiene que seguir fortaleciendo las competencias en lo que es cambio climático, porque muchas veces los conceptos de cambio climático son nuevos, ¿no? Y además de eso, se requiere información de los escenarios a futuro de cada peligro, porque recuerden que esto no es de un momento, ¿no? El tema de cambio climático es ver proyecciones a futuro de lo que va a pasar. Entonces, esas son otras las lecciones aprendidas. Además de eso, si bien es cierto, el ente rector en cambio climático es el Ministerio del Ambiente y nos habla que el Ministerio de Salud tendría que dar medidas adaptativas, también nosotros hemos reconocido que el Ministerio de Salud también es un emisor de gases de efecto invernadero. Por tanto, también tenemos que implementar medidas de adaptación. Los desafíos, pues incorporar este proceso de lo que es cambio climático en nuestro documento de gestión del Ministerio de Salud, en nuestras planificaciones, tanto estrategias operativas y programas presupuestales para contar con financiamiento, porque a diferencia de lo que es emergencias y desastres, que existe un programa, cambio climático no tiene un financiamiento establecido. Trabajamos bastante con lo que son cooperantes. Asimismo, continuar el desarrollo de cursos, ¿no? Webinar, entre otros, dirigidos a recurso humano para lo que es variables climáticas y ambientales. Y continuar la asistencia técnica y acompañamiento a las regiones, que es muy importante. Recordar que esto de cambio climático es nuevo, entonces para ellos es un poco más complicado poder implementar esto. Y continuar con investigaciones que articulen este tema de salud pública con escenarios climáticos a largo plazo. Iniciar el diseño de medidas de mitigación, así como lo hemos hecho y aprobado de adaptación, hacer el de mitigación, e involucrar en el trabajo recursos humanos, pero ya algo más operativo en los establecimientos de salud. Bueno, y eso sería la presentación de cómo el Ministerio de Salud viene implementando esta gestión de riesgo de desastres, articulado al cumplimiento de los ejes estratégicos del Plan Andino de Gestión de Riesgos y Desastres 2018-2022. Muchas gracias.
Magnífica presentación, Nilton. Han llegado muchas felicitaciones por el trabajo tan excepcional que se está haciendo desde el Ministerio de Salud y también el reconocimiento que se hace a la articulación y a retomar las líneas estratégicas del Plan Andino de Gestión del Riesgo de Desastres y también otros instrumentos nacionales como el Plan Estratégico Institucional Ampliado. Muchas gracias también por haber hecho ese ejercicio tan interesante de análisis de logros, desafíos y lecciones aprendidas en relación con cada una de las líneas estratégicas del Plan Andino de actualización de la normatividad, reducción del riesgo, preparación y respuesta frente a emergencias, mecanismos de asistencia, capacidades y competencias del talento humano y el cambio climático. Básicamente también nos recuerda todo el esfuerzo que hay que seguir haciendo, articulando e integrando el abordaje intersectorial multinivel. Felicitaciones, muchas gracias. Vamos, por favor, a pasar a un momento muy especial de diálogo en respuesta a preguntas que han llegado, comentarios, todos muy interesantes. Antes queremos agradecer a todas las personas que están conectadas de los ministerios de salud de Bolivia, Chile, Colombia, Ecuador, Perú, Venezuela, Argentina, Cuba, Estados Unidos, Guatemala, Honduras, México, Panamá, Paraguay, República Dominicana, Uruguay, entre otros. Y también queremos agradecerle a todos y a todas los bonitos mensajes que nos han llegado. Les pido por favor en este momento encender la cámara a todos y a todas. Quienes están por favor en sala, encendamos la cámara para pasar a este momento. Nos han llegado muchas preguntas, pero solamente vamos a formular una a cada ponente. Las otras me comprometo a dar respuesta en el Facebook y en el YouTube Live con el apoyo, por supuesto, de las y los ponentes. Para Viviana, por favor, Viviana, nos preguntan, ¿cuáles son las principales barreras para la gobernanza en gestión de riesgos de emergencias y desastres? Para Diego, por favor, ¿cuál es la importancia del plan andino, de los dos planes, el de cambio climático y el de gestión de riesgos para el logro de los pasos presentados? Y para Nilton, ¿cómo se incluye la participación de la sociedad en los procesos de gestión de riesgos? ¿Sí podría comentarnos una experiencia particular, por ejemplo, con pueblos originarios? Adelante, por favor.
Bueno, arranco yo, supongo.
Sí.
Entonces, digamos que la gobernanza entendida como la interacción entre organizaciones, comunidades e instituciones, digamos, tiene un escenario bastante amplio, pero así como es de amplio, es de complejo. Pero yo creo que uno de los principales elementos, y sobre todo para la gestión del riesgo, es en términos del lenguaje. O sea, que si nosotros desde el sector salud hablamos de determinantes sociales, probablemente nuestros compañeros del sector ambiental o nuestros compañeros que trabajan con hidrocarburos no lo comprendan. Entonces, para mí uno de los principales elementos es el lenguaje. El segundo es una visión, que hay que tener una visión territorial, más allá, digamos, de la misión de la institucionalidad. O sea, si tú eres ambiente, te dedicas solo a lo ambiental, de salud, no. Hay que tener una visión territorial y creo que eso impide un poco, o sea, eso junto con el lenguaje limita un poco el ejercicio de la gobernanza. Pero también creo que hay otra cuestión que es frente a la información y a la participación. Y esa información, digamos, entendida desde cómo democratizo la gestión del conocimiento. Cómo realmente esa democratización del conocimiento no solamente me va a permitir entender mejor el riesgo, sino que también haya un ejercicio participativo en términos de mejorar la gestión pública y la transparencia. Entonces, creería yo que si nosotros utilizamos o en esos sentidos compartidos que tenemos que la gestión del riesgo, logramos tener un lenguaje en el que todos, si yo digo determinantes, todos entendamos lo mismo, o si digo peligro, todos entendamos lo mismo, es bastante importante, y sobre todo la visión de territorio, más allá de la visión institucional. Creo que esos dos elementos nos permitirían mejorar la gobernanza para la gestión del riesgo.
Excelente, muchas gracias. Adelante, por favor, Diego.
Muchas gracias, Berta Luz. Bueno, en cuanto al tema de la importancia del Plan Andino de Salud, de Cambio Climático y también del Plan Andino de Gestión de Riesgo de Desastres del Sector Salud, ¿cuál es la importancia de este tema para el logro de los siguientes pasos? El primer elemento es el entender que estamos hablando de un acuerdo que está firmado al más alto nivel no solo por el Consejo de Ministros, ¿no es cierto?, sino que estamos hablando de que las presidencias de la República, a través de la ratificación de estos espacios, pues está de acuerdo a la par del resto de presidentes de la República, de la subregión, de la zona andina. Y esto nos permite tener un apoyo directo y una voluntad de implementación declarada, y como es declarada, pues tiene que ser cumplida por los elementos sectoriales, en este caso a través de los ministerios de salud. Entonces, ese es el primer elemento. El segundo elemento es que permite también traducir estas y aterrizar estas experiencias suprarregionales, ¿no es cierto? Como es el marco de Sendai, como lo fue Hyogo en su tiempo, permite que esto sea aterrizado hacia las realidades de los países andinos que están participando en este proceso. Entonces, esta alineación con los objetivos globales que integran también al cambio climático y a la gestión del riesgo como espacios de trabajo, pues permiten que se pueda tener ya la cancha trazada y poner a los diferentes actores a jugar con este desafío y cumplir objetivos que están orientados dentro de los mismos esquemas. Otro elemento importante es que al ser planes regionales, permiten que existan espacios de transferencia de conocimiento, de intercambio de conocimiento, un benchmarking, un sano benchmarking entre los diferentes países. Hay países que tienen avances en X o Y procesos, y estos pueden ser compartidos con sus pares, de tal forma de hacer una suerte de una atarraya múltiple, ¿no es cierto?, que vaya jalando por diferentes espacios, y que las instituciones y los funcionarios, pues que tienen algo de mayor recorrido en la resolución de cierto tipo de problemas y que hayan tenido experiencias positivas o negativas, puedan ser puestas en contexto del resto de colegas que están enmarcados en este espacio. Por otro lado, también permite que se generen cierto tipo de proyectos que son de interés común, como es el caso del proyecto que se está manejando en este momento, que es el proyecto Readiness, que es un proyecto que busca utilizar parte de los dineros de los fondos de ambiente, los fondos verdes, ¿no es cierto?, de los diferentes países, para generar un proceso de integración y de gestión del riesgo y del cambio climático en el sector salud. Entonces, ha permitido también que se aporte desde diferentes sectores y se hagan el cabildeo necesario para que estos recursos también puedan ser posicionados en el trabajo de la gestión del riesgo y del cambio climático. Otro espacio interesante es que se sistematizan experiencias también exitosas de nivel operativo, como es el caso de la misma sistematización de establecimientos de salud sostenibles y resilientes, que busca encontrar esas experiencias estratégicas y operacionales que han logrado que los sistemas de salud entren dentro de este marco de seguridad, de continuidad operacional, de sostenibilidad, de amistad con el ambiente, y que sobre todo estén en la capacidad también de enfrentar las diferentes amenazas a las que está expuesto cada uno de los elementos. Una de ellas, y quizás la más importante, es el cambio climático, que como sabemos bien, pues nos puede exacerbar las amenazas y generar más presión sobre el sistema de salud, pero por otro lado también el sistema de salud es uno de los contribuyentes más fuertes hacia la generación de nuevos momentos que generen un estado más crítico de las condiciones que incrementen la velocidad del cambio climático. Entonces, estos son los elementos que logro identificar al momento de cuán importante es tener un plan regional y de qué espacios pueden gestionarse luego de que las máximas autoridades, tanto nacionales como sectoriales, se han puesto de acuerdo para trabajar en estos dos grandes espacios, la gestión del riesgo de desastre y la gestión del cambio climático, como les decía, como proveedor o receptor de una amenaza que afecta o que podría generar el sector salud.
Bonita y amplia respuesta. Muchas gracias, querido Diego. Adelante, por favor, estimado Milton. La
Sí,
respuesta.
bueno, primero comentarles que cuando nosotros elaboramos algún documento en lo que es gestión de riesgos de desastres o algún enfoque, que diga o algún plan, lo hacemos a través de los enfoques. El enfoque de interculturalidad siempre está presente en nuestros planes en gestión de riesgos de desastres y nuestra normativa. También recordar que el Ministerio de Salud dentro de sus o direcciones tiene una dirección de pueblos indígenas u originarios, en el cual, digamos, cuando el ministerio o cuando la DIGER elabora o fomenta algún tipo de plan, las actividades también se les convoca a ellos y proponen intervenciones para favorecer a esta población de pueblos originarios, indígenas y originarios. Asimismo, tenemos el Comité Intergubernamental en Salud, que es una plataforma donde ingresan ahí todos los directores regionales de salud, en el cual identifica prioridades de intervención. Una de las prioridades que yo podría mencionar es que en el marco de ese comité intergubernamental se aprobó un plan en este tema del plan de COVID, se aprobó un plan que se llama Intervenciones y Mitigación y Contención contra la COVID-19 implementadas en pueblos indígenas de Perú, Brasil, Colombia y Ecuador. Se trabajó bastante ya a través de las direcciones regionales de salud para ver el tema de los pueblos originarios y no contactados y se tuvo que tener un presupuesto. Básicamente los enfoques fueron en dos puntos: en caracterizar la accesibilidad de los servicios de salud a esas zonas de difícil acceso, y el otro tema es el tema de interculturalidad. Y en el tema de interculturalidad, lo que se trabajó bastante con promoción de la salud y comunicaciones es adaptar toda esa información que se tenía, digamos, de panfletos, de comunicación, a un lenguaje que ellos pudieran entender y de esa manera, digamos, facilitar el tema de la intervención, sobre todo explicando el tema de lo que viene a ser la vacunación, ¿no? Entonces, de esa manera, digamos, se hace una articulación entre el Ministerio de Salud, la Dirección Regional de Salud, el organismo que ve esto, que es la Dirección de Pueblos Indígenas, y cómo estos se pueden, digamos, ir implementando en los diversos planes en emergencias y desastres, en este caso, en la intervención como se hizo en COVID, ¿no?
Excelente respuesta. Muchas gracias, querido Milton. Vamos, por favor, en este momento les pido encender la cámara. Milton ya nos había dicho que está en terreno, en campo y que tiene dificultad para encenderla. Queremos agradecer todas las preguntas realizadas. No alcanzamos a responderlas. Todas en este momento las vamos a responder por escrito a cada uno, a cada una. Y también, como saben, las tendremos en cuenta para definir los temas de los próximos seminarios web. Valoramos su participación e interés. Para cerrar este espacio de ciclo de preguntas y respuestas, le pido a los ponentes, en el orden de que hicieron sus intervenciones, nos dejen un mensaje final en 1 minuto. Sí.
Bueno, mi mensaje realmente es para usar.
Message is to use the meteorological or climate information to generate early alert systems and to have better plans for land programming that would allow us in the long term to do a structural exercise to avoid those risks. In addition, I would like to thank Dr. Maria del Carmen and, of course, Horas, that I bring it in my heart. Thank you so much for inviting me. It was an honor for me, and see you next time. Thank you. dear Vivi. Go ahead, dear Diego. Thank you, Berta Luz. Well, message is precisely towards governability lines, over the line of being including the climate change variable to risk management in the agenda of decision making through generating administrative, financial, technical sustainability, and that will allow us to have strength in terms of access to decision maker, and that the decision maker has the team of risk management decisions that they will take be oriented towards to generate sustainability process and guarantee the long-term investment. I would like to repeat my thanks to Maria Carmen, Viviana, to you, Berta Luz. You keep us all active us all the time and always managing these specific topics for health, which are extremely complex but extremely necessary in the moment of a critical situation. Once again, on behalf of the Minister, Jose Suarez, big hug to all of you and my best wishes. Very kind, all of you. Thank you. Dear Nilton, thank you, Berta. One of the things that I would like to mention is that we need to understand that the implementation of disaster risk management has to be at a multi-level, international level, national level, provincial or local level, be a multi-sectorial level. All the sectors need to be committed with the implementation of the disease risk management and also worldwide. Not only public servants, but also the population at large and the original peoples. So by coordinating that multi-sectorial and multi-level, we will have a better implementation of the disaster risk management. I would also like to thank Dr. Maria Carmen Calle, very kind for your invitation for this webinar, and let's hope we be invited one more time. Again. Thank you. Thank you, Dilton. Will do. Now to close, Dr. Maria Carmen Calle has the floor. So on behalf of the Andean Health Organization, she will close this webinar. Well, this has been a wonderful event. I would like to thank from the bottom of my heart to the three speakers that from different angles have talked about this topic. Been extremely important. Yes, we need to speak the same language. We don't speak the same language. And many times, not only because we don't have the same tongue, because our conceptual framework are different. And that, for me, is the most important problem. I was a vice minister in many times, have met with the Ministry of the Environment, with other ministries, and we don't necessarily speak the same language from the point of view of disasters and climate change, not necessarily. The other topic that I believe it's important is the territorial topic. When we talk about territorial, we always talk about national and local, but as Diego mentioned, at some point, the regional topic is important because anything that happens in one place affects other sites. And more in the case of our countries that we have mid to high income, except for Bolivia, but we're fully aware of this inequality inside the country that we have. I think that that's obvious. And another thing that I believe that it's significant or a flagship for the Andean Health Organization is a climate change. And climate change and we're fully aware that the climate change is deciding what the history is, and if we don't realize that, we are not doing things well. And the disasters issue also takes us that we're going to start to feel it later in terms of climate change and disasters, they result in migrations. We're not only talking about migration due to political reasons or economic reasons. We see displacements of 1 billion people, and one of the reasons are disasters, climate change. I consider that it is extremely important what Nilton mentioned of the need to have a multi-sectorial approach with multi-stakeholders and levels, but we definitely have to have a long-term look, something that we're still lacking as countries. When you go to Europe, you see a 20-year plan. That as simple as that. When you go to Latin America, you have a plan for 2 years, and let's see if anything happened, because we are quite complicated as a region, right? But now the entire world is complicated. Europe is full of migration. There we have the Ukraine. We should not forget Syria. So at this moment, there is a world crisis in many aspects. And sometimes the emergencies prevent us to see what's coming later. We are not taking care of this planet for us. We know that that is not the case. This is for the following generations. And there are precise and exact measures that may reverse many things. There are many things that cannot be reversed. Let's be realistic. But something that Diego mentioned of the readiness project, which we are trying that the 6 countries work. It's a very important project, way of governments to say that they're really interested in this topic, because the health services generate problems. So we need to face this clearly. Why do we need to do it? And it is not that I just from health, but we need to fight to have a better positioning in this topic, that I feel that we still need to work. We should not forget governance. And in governance, we are all in this capacity of coordinating, harmonizing, this capacity that together we can do things better. Still, it's not that easy in our region. I think that we're making progress. I think we're doing it better and better, but we need to be positive. We're doing it better and better, but there's still many things to do. So I would like to thank your participation, because in addition to all the knowledge that you can have, you are committed with this topic. And I think that that is important. I always mentioned in several scenarios, not only the attitude, it's mostly the commitment with those. I would like to thank Bertita, that as you know, Bertita is the woman for this topic in this Andean Health Organization who promotes us and is always there. So I think in the Andean institution, she's fully committed in our institution. So I would just like to thank you again, thank the Andean Health Organization, thank to all the people who are behind stages, to Marisela and all the Andean Health Organization. I will not forget anyone, Rob, Yadira, Milagros, Elsa, to everyone who has to do that we've reached webinar number 144. I'll see you next Thursday. And the topic for next webinar is, what's our next topic? We have so many that actually. Today is the 13th. For 2020, we invite you to be with us. We also invite you to visit www.horasconru.org. Everything is there. Everything that Bertalu has mentioned is there. All the effort done from the 18 committees, 8 working groups, 3 subcommittees, everything that the Andean Health Organization is there. And as you know, all the webinars are posted. And actually, it's an excellent idea because we have an evaluation of the first webinars, and the views are very high. So we are contributing to this continuous interlearning. See you next Thursday at 11 a.m. Thank you.